Right, so since it's 7, we can go ahead and get started. So hello, everyone, and welcome. My name's Tiffany Fernandez. I'm a licensed clinical social worker in the state of Connecticut, just in case you're not currently residing in Connecticut. And I'm currently working as a psychotherapist, and I'm also a current member of the PALCUS Healthcare Committee. So today's webinar is being hosted by PALCUS. If you're not familiar with PALCUS, we're the Portuguese American Leadership Council of the United States, which is a national nonprofit organization focused on strengthening the Portuguese American community through leadership, advocacy, education, and cultural connection. Our mission is to bring people together, amplify our community's voice, and create opportunities for engagement across the country, and we're very delighted to host this conversation and have you all join us today. Just a side note as well, throughout the presentation, if you have any questions that come to mind, please feel free to put them in the chat because we're going to make some time towards the end for like a brief Q&A. Alrighty, so today we're joined by Dr. Ryan Wade. Dr. Wade is a psychiatrist board certified in General Psychiatry, Addiction Psychiatry, and Addiction Medicine, who completed medical school and a General Psychiatry residency at Eastern Virginia Medical School, followed by completing an Addiction Psychiatry fellowship at Yale University School of Medicine, where he was the first fellow to train primarily at the Connecticut Mental Health Center. Dr. Wade is currently the Director of Addiction Services at Silver Hill Hospital, where he serves as the lead psychiatrist for their dual diagnosis residential treatment program, as well as the medical director for the dual diagnosis intensive outpatient program at Silver Hill, New York. Dr. Wade maintains academic appointments at Yale University School of Medicine, City University of New York School of Medicine, and the Frank Netter School of Medicine at Quinnipiac University. So today, Dr. Wade will be presenting on understanding mental health, addiction, and the impact of stigma. He'll be providing an overview of mental health, substance use, and their treatments, followed by a review of recent public health data trends and how they are impacted by stigma. Dr. Wade, thank you so much for being with us tonight. We're really excited to have you, and I'll turn it over to you.
Excellent, and happy to be here, and thank you for this opportunity and the kind introduction. So I'll try and share my screen here. One second. There we go. All right. All right. Everybody can see this. Looks like good. So
Yeah.
Excellent. Thanks, Susie. So today we'll be talking about mental health, addiction, the impact of stigma. Working as an addiction psychiatrist, I tend to see a lot of beliefs, a lot of biases, a lot of the way in which people view these certain conditions and how they can really impact both people's mental health and their ability to seek treatment, their willingness to seek treatment. And so I think it's an important topic, and certainly something we could talk about for hours, and I'll try and distill down some of the higher yield points and get through this in a timely fashion so we can get to some questions and everything that people might have. So I'll try and keep it pretty high level, at least. And so no conflicts of interest, no financial obligations to disclose. That unfortunately nobody's paying me for any of this. So a quick agenda, we'll run through some background on mental health and the ideas of stigma, some basic statistics, with some larger surveys and everything that we collect some of this data on, looking across the US and some of the impacts that some of this has, and a basic overview of treatments. There's a real broad range of treatments that people can use, so it'll be not too specific getting into that, but if people have questions more specifically at the end, certainly can talk about things a little more in depth. So as far as the background, one of the things that I've run into a lot when people are asking about these sorts of things is how to know when to seek treatment. People are often unsure, and we all deal with mental health. Many of us have some experience with use of a substance of, alcohol, cannabis, what have you, things that are legal, but that still might be causing people problems. And, I often hear questions like, is this something I should seek treatment for? I've always felt this way, or isn't this normal? Doesn't everyone feel like this? Doesn't everyone have this? Or oftentimes people are downplaying the severity of some of the discomfort they might be in, and I don't know if it's that serious. I don't know if I should seek help, or, I don't necessarily have an issue or anything. There's just a lot going on right now. And, I don't think I actually have depression, or, I don't think I really have trouble with anxiety. There's just a lot going on right now. Just really stressed. And sometimes all this is accurate, right? Sometimes there are just some difficult stretches, and it doesn't necessarily require professional assistance. Sometimes we do experience these phases in life. Um, and we often can get through these times in life without necessarily seeking any sort of professional help. Um, and mental health, unlike sort of a physical injury, these are all symptoms, these are all conditions that we have some exposure to in life. We all have experienced worry about something. We all have experienced a time where we felt sad about something. It doesn't mean that we all have anxiety disorders or depressive disorders. And so I think these are really good questions, and I think it's a good place to start in when we're talking about things from a pretty high level. And so, when it seems more prudent, at least when anyone would come to me and ask about these sorts of things, when it seems more prudent to seek treatment, there's a few things we would commonly find to be more in the realm of a disorder, if you will. If there are physical symptoms that are coming with some of this emotion, right? If we're a little bit worried about something, and we might prepare a little more. Like if there's a job interview, and you want to do well with it, you might do some research on the company or the job that you're applying for, and that worry actually motivates us a bit. But when that anxiety starts giving physical symptoms, and you're in that job interview, and you feel your heart pounding, you feel like you're shaking, stuttering over your words, it really can be impacting performance. It can be negatively impacting people, and so that would be more of a sign that, hey, this anxiety, this is more of a mental health condition. This might be something that I could seek treatment for. It's getting disruptive. Similarly with depression, it can be really low energy. There can be a lot of changes to our sleep, and our desire to engage in activities, or our ability to engage in activities. Having some of those physiologic things that come up that are really tied to the emotion, and sort of out of the norm, it's often a good indicator that these are symptoms that have progressed. Like this is more of an actual condition. Similarly, if we're experiencing the emotion and it's uncomfortable, and it's lasting a particularly long time. I'm not just feeling down for a day or two, and now it's getting to weeks, and I feel like I'm not just coming out of it. Or, these periods of time where I'm having the lower moods, they're happening more frequently. And, when there really is a significant shift compared to what we're accustomed to. Similarly, if we're having anything in our day to day that's getting disrupted by it, it's okay. Maybe I feel a little more anxious today, but nothing particularly changed. I just felt a little more uncomfortable. But if it's getting in the way of, I don't want to do this task because I'm so anxious. I don't, I'm feeling too nervous to leave the house, or I don't, I'm so nervous I can't go to work today, something like that. Or avoiding conversations you might need to be having in your personal life because of this. This happens once in a while, not necessarily a big concern, though. If we're noticing it more frequently, it can be more of a condition to seek treatment for. Where we often see that sort of threshold crossed, or when people often do actually seek treatment, it's when it's impacting our relationships. It's when other people are noticing, or they're seeing something that's particularly disruptive. And often people's family members, or their spouse, their partner, can really urge them into treatment because they're finding the emotional states are negatively impacting the relationship. Um, and this applies for substance use as well, and you'll see kind of throughout the presentation, I sort of work in aspects of addiction and substance use. That's a big focus of mine in the world I work in. They often go hand in hand with mental health concerns. And so, similarly, if the alcohol consumption, the weed use, whatever substance it may be, if it's really starting to impact your relationships, that's when it can be more disorder. That's when it can be time to seek treatment. Um, and so there is this sort of question as to why is it more of a question? Why don't people just seek out treatment? Like, well, what prevents us from doing so? And some of it is sort of what we just covered about, the uncertainty of like, is this actually something we treat? It's not as clear as a broken bone might be, where that this there's a deformity like this needs to be addressed, and so there's a sort of gradient to it. There's a spectrum of these sort of conditions. So sometimes it's the uncertainty, sometimes it's access, whether it's difficulty with health insurance or cost, or even availability in terms of finding a provider, whether it's therapy or for medication. The cost as part of access. Oftentimes, these go hand in hand. It may not be that there's no accessibility to treatment. It just might be very costly to get treatment. And if you're searching for more cost-controlled treatment, there might not be as much accessibility. We see that an awful lot. But the one I do want to touch on just a little bit more in depth, because getting into cost of treatment and insurance companies and everything is going to be well beyond the scope of what we can cover today, is the idea of stigma, and how our own biases can affect these our pursuit of mental health treatment, or our perception of people with mental health conditions, or substance use disorders. And so stigma, this is a quote I took directly from SAMHSA, the Substance Abuse and Mental Health Society of America. In working with mental health and substance use, their big focus is on increasing access to treatment for folks, and increasing quality of treatment. And stigma often gets in the way of that. So they comment on health-related stigma specifically. It's describing a sociocultural process in which social groups are devalued, rejected, and excluded on the basis of a socially discredited health condition. And when they say socially discredited, often there's this sort of concept of people's own influence on having the condition. And so, our perception of people's influence on a substance use disorder might be that, well, it's sort of their fault in the first place. Like they're the one using, they're the one drinking the alcohol, they're the one using the drugs. I don't feel bad for them in a sense, because they're doing it to themselves. Or sometimes we can even see that with certain conditions like obesity or diabetes. You can sometimes people look at this as a choice people are making in terms of their activity and their and their dietary habits and that sort of thing. Whereas most people that develop a cancer or something of that nature, they wouldn't socially discredit most of their cancers people might develop as saying it's not necessarily their fault. They wouldn't have influence over it. And so there tends not to be as much blame or detracting from someone receiving treatment for that, as opposed to treatment for, substance use disorder, or sometimes for certain mental health conditions that it feels like we have the perceptions we might have some more control over. And often, stigma can be influenced by a lot of things, but often where we see it play out the most in terms of our healthcare system really is by the impacts that we see within the media at large, and then certainly social media can make a large influence on our perception of things nowadays. But also the government. The government has a large role to play in a lot of this, and if the government were to say that something is illegal, there's this sort of moralizing effect that happens when a substance becomes illegal, there's people have this sort of hesitancy to engage with it, or they might have certain beliefs about it, or because it would be breaking the law to use a substance as well, not just to use something. There tend to be these moral sort of beliefs that surround it. Um, and historically, a number of these laws and sort of bills that were passed by the government, particularly back when our country was still growing and really developing, a lot of them had racial and cultural bias, and the the nation's first drug law was actually the San Francisco ordinance against opium dens, and part of it was they were having America wanted to control a lot of the immigrant population coming in from Asia, and they were often coming in San Francisco and out in California, and that's where opium was coming to the country from. And so there was a lot of racial undertones to the way in which they would police opium dens and these sorts of laws. And similarly, for the Marijuana Tax Act of 1937, even the use of the term marijuana is racial undertones to it. The idea of using the term marijuana was really to vilify cannabis, which is the more appropriate term, the more scientific clinical term would be cannabis. Marijuana was sort of slang to indicate the cannabis that was coming into the country from Mexico, and it was really intended to sort of fearmonger at that time, and placing these sorts of restrictions on it ultimately had a sort of moralizing and effect, not to mention how much it did to our jail systems and criminalizing the actual substances. And there's a sort of deterrent that ends up there, and there's stigma that comes with crime and imprisonment beyond just even the substance use. And we're kind of also seeing that in reverse at this point, with a lot of the decriminalization of cannabis, and in so many different states, and greater permission for both medical and recreational use. It's reduced stigma significantly in this country. That there's rising rates of cannabis use in just about every age group and demographic, compared to 10, 20 years ago, certainly. And the idea being that there's less stigma, there's less of a bias against something like this, because the law really does inform it, to a large degree, for us at least. And so it's from a governmental standpoint, being careful about these sorts of things really is relevant. Though the idea that media also takes this and runs with it to a degree, whereas if there were things like this that were crimes, that there were things like this that were getting people into trouble. I mean, this is stuff that makes news, right? And certainly within the social media realm, that posting about things, talking about them, really can shape the way in which we really perceive a lot of these different substances being used. Also, how we perceive these different psychiatric conditions. So I'm going to run through some quick statistics and talking about mental health and substance use within the country. Probably our best source of data for this sort of thing is the National Survey on Drug Use and Health, which is run by SAMHSA, Substance Abuse Mental Health Services Administration. The data is put out every single year. It's made publicly available. They've been doing it for about 12 years now. And I looked earlier this week. They're due to release their most recent set of data pretty soon. It's usually July, August, somewhere in there, but not yet. So data I have is what was released last year. But it's a survey that touches a great number of people in the U.S. This past year was about 70,000 respondents, and certainly for a country of 350 million, somewhere in the neighborhood, obviously not a fully representative sample. Though also a lot of data points, right? It's the largest set of data that we get every single year. And what is nice about them continuing to do this year in and year out is they can trend the data over time. And that got a little murky during the pandemic, though. At least over the last 4 years, they've been able to continue with creating some of these shorter term trends, having a little more consistency after sort of disrupted in 2020. It, there's a lot of data out there, and it's anybody can access it going to the SAMHSA website. Yeah, if you're interested, it's really is more data than you can know what to do with in any given year. So, um, the one limitation I do find with the study or with the survey every year is that you have to have a registered address in order to participate. And so this doesn't include people that are incarcerated or people that are experiencing homelessness. Also doesn't include active duty military folks often. But we certainly see greater proportions of mental health concerns, psychiatric diagnoses, as well as substance use disorders in individuals experiencing homelessness, as well as those that are incarcerated. So, if anything, this might be undershooting our total population a little bit, but it is effectively the largest set of data we get every single year. And so I'll go through just a few of the higher point uh, data that we got in this most recent survey. So we see that over 58% of America is using some kind of substance within the past month. Now, granted, all the ones here on this slide are things that are generally considered legal, and they are. I mean, certainly cannabis isn't in every state at this point, though a lot of the states it is legalized, and so that these comprise the vast majority of the substances that are used. Though there is a decent percentage of illicit drug use that we see within the country every year. Um, the good news here, looking at some of these trends, are that a lot of things are actually improving. If in the grand scheme of things, like looking at the big data, we see fewer people using tobacco products. We see less binge consumption of alcohol, less heavy alcohol consumption, less cocaine consumption, and opioid misuse. Um, there are some things that are worsening, though. I mean, no, we're seeing more people using cannabis and more people using illicit drugs overall within the past year. Um, the within the past 4 years. I'm sorry, this is trending since 2021. Um, though overall, it appears that there are a lot more numbers that are improving than there are ones that are worsening. And so sometimes this can give us a really good sense of where we should be turning to from a public health standpoint and what we should be doing in terms of treatment. Um, what trends are becoming more problematic in the U.S. And so certainly cannabis use is the one rising at the greatest rate. Um, so uh, we see that although the number is actually increasing slightly with illicit drug use, we see it reducing in terms of opioid use, which has been a real focus of the U.S. in the last several years, partly because of the danger of opioids and the risk of overdose. Um, though we are seeing technically slightly a greater proportion of people using illicit substances just in general. Um, the idea of misuse versus having a diagnosable, opioid use disorder. The idea being whether this is a sustained sort of pattern and how disruptive it is to people's lives versus, isolated incidents of misusing prescription opioids. And so that's where the discrepancy in some of those numbers come from. But overall, we are seeing a decrease, which is great. That's it's been a while since we started to see the opioid use numbers come down in the data. So unfortunately, we're seeing some improvement there, which I think is great for safety for people within the U.S. We also see huge treatment gaps. This is a number that has only changed very slightly since they started collecting this data um, in 2014. And so, we see here that about 20% or so of people with a substance use disorder actually ended up receiving treatment. within the last year. That's actually gone down somewhat since the year before. But that number has kind of hovered between 10 and 20%, basically since they've started doing this survey. Um, Unlike those receiving treatment for mental health concerns, which has slowly but steadily rose, over the last 12 years. And so there, I suspect this is somewhat of the influence of stigma in the sense that there are more resources out there for treatment than before. There are, opportunities for people to seek substance use treatment, and we're really working on making those, accessible and making them known. Though we are still seeing a pretty significant difference between the people that identify having difficulties with substance use and those that are actually receiving treatment. Um, and 10 to 20% really isn't, certainly not cutting it, especially compared to the about 60+% that are getting mental health treatment. Um, we are, one thing that we don't have as much data to trend, as personally I would like, but that we are seeing in the more recent sets of data is that vaping is quite prominent. Vaping used to be something that was more of a novelty, 10, 15 years ago, maybe. And most cannabis that people were consuming would be smoked, occasionally edibles. Nicotine was almost always smoked, or maybe it'd be chewing tobacco. But vaping is by far the most common. You can see with these bar graphs here. In really any age range, there is a good proportion of people that they're only consuming these sorts of substances through a vape. Um, and so that's something that's more newly added to the survey. And so we don't have a ton of trend data looking back several years to see how much it's grown, though it certainly is quite prevalent. And then looking at a lot of the mental health concerns that the survey touches on. This was the first year that they actually pursued seeking out the anxiety symptoms as part of the survey. They often would look at major depressive episodes, and then they would look at any sort of mental health diagnosis, and they would look at serious mental illness as a category. But they broke down some of the questions this year, looking specifically at anxiety disorders as well. And so what we saw was that the percentages stayed relatively similar in terms of any people that identified having a mental illness within the last year, as well as those that have been diagnosed with a serious mental illness. But we see just over 20% of adults identifying symptoms of generalized anxiety disorder, and about a third of those, looking at around 8%, 7 to 8%, having moderate to severe symptoms of generalized anxiety disorder. That number was almost doubled when we were looking at adolescents as well. So, 2 out of every 5 adolescents are having symptoms of generalized anxiety disorder, which is, I hate to say, not a surprising amount, knowing the landscape that children are growing up in, though it is quite staggering to see when you can consider that even all adults looking at all sorts of mental illness, you see about a 23% rate of just having any sort of psychiatric condition, where looking at 42% of adolescents have meet criteria for this one specific condition. So anxiety is rampant amongst adolescents and our youth. It really is. I'm glad it's something that we're surveying now, though it is a pretty startling number. That's quite high. Interestingly, despite that number being so high, looking at the anxiety, we actually saw a pretty significant downtrend in terms of major depression. About 25%, about a quarter fewer adolescents identifying having a major depressive episode in the last year. We also saw reduction in those that are reporting thoughts of suicide or of attempted suicide. We also are seeing reductions in those that have co-occurring substance use disorders. And so there's a a huge improvement that we're seeing amongst adolescents in a lot of the mental health realm. And certainly we don't have prior comparison points for what I was just referencing as far as the generalized anxiety, though it is worth noting that we're seeing some improvement on the adolescent realm, which I think is encouraging, despite just how anxious our teenagers and young adults are seeming to report, at least. And so get into a little bit of the impact here. Certainly the impact of any of these diagnoses can really wreak havoc on individuals, and certainly treatment can be warranted for many of these instances. But looking at this from as big a picture as we can, certainly looking at the survey data and some of the larger data figures for the country, we also look at public health expenditures. So about $140 billion of our healthcare spending is on mental health and substance use treatment. And so that's quite a bit. It's certainly not quite in the realm of many different health conditions and like cardiac conditions and strokes and that sort of thing. But there's also a little bit with this number that's not quite telling the whole story. There are often a lot of medical treatments that come to related conditions of some of these mental health or substance use concerns, right? Um, just treating medical conditions that are related to excessive alcohol use amounts to almost $20 billion annually, right? That's not something that's included in this expenditure because it's not an expense for alcohol use disorder. It might be an expense for liver failure. It might be, an expense for, esophageal cancer or something that can be related to, excessive alcohol consumption. And so, as much as $140 billion in spending, it's a bit eye-popping. It's not even close to telling the whole story. That would, for example, that also wouldn't include healthcare spending on lung cancer, even if the lung cancer was related to smoking, for example. So it really is. These conditions really are affecting us in a very global sense. Um, you know, that number also actually doesn't include anybody at state psychiatric institutions because that's all like government direct spending, as well as those that are incarcerated in state or federal prisons, and many of those individuals are receiving psychiatric care as well. And so, it's a huge public health burden, right? And it's not that it's all about the money and everything like that, though it does seem to be a decent way to measure things, especially when we consider how much the government and insurance companies are willing or not willing to spend for medical care. I mean, these numbers end up staggering. So, um, and additionally, I mean, that's beyond even the psychiatric care for these people. I mean, almost half of people that are in state prisons, almost half of incarcerated individuals in state prisons, their primary charge is drug related. And certainly that doesn't mean that they all have substance use disorders, though uh, one would think they're certainly more likely to have a substance use disorder if they do have a drug related charge. And so we would expect that these folks are probably utilizing a lot of these kinds of services. So, uh, relative to the overall U.S. medical expense, that 140 billion is only about 5.5%. But when we look at the impact that these conditions might have on other medical conditions, um, uh, uh, even things like anxiety having a much greater rate of inducing atrial fibrillation or a heart arrhythmia, and all of these things are intertwined, and as large as that number is, I expect it's actually quite low in terms of our actual impacts here. So, going to go over treatments just sort of briefly because I do think that it's an important thing to touch on relative to um, the idea of when do we seek treatment, when should I see someone for this, or when should my loved one see someone for this. Um, there's a concept within medical care as well, but certainly within the mental health and substance use realm of how intense does the care need to be. There are different levels of care. Certainly people can appreciate that, an emergency or a crisis and someone's going to the ER in an acute crisis. That's a different sort of care than if someone is showing up for a once weekly therapy session, right? We can appreciate the level of intensity or the level of need in those situations are different. But there are a number of levels sort of in between that. We often think of outpatient therapy as sort of the lowest level of care. And I would argue that in this day and age, just a notch below some of that would be doing telehealth only care. Yes, you're seeing a provider and or a therapist, but not even in the same space, not able to provide some of the other sort of services that you might within an in-person clinic and all of that might be less intensive, not even having to get up out of bed to have your appointment. But beyond just doing regular outpatient appointments, there are intensive outpatient programs where people are spending, 10 plus hours a week doing some amount of treatment, whether there's often group-based treatments and individual therapy sessions, but spending a good chunk of time actually in outpatient programming, not solely just individual appointments. Partial hospitalization programs are uh, generally the majority of the day and the most days out of the week. So it's often at least 5 hours, 5 days a week. And so people aren't quite hospitalized. They're still returning home. It's still an outpatient type of program, but you're spending a lot of time in treatment. And so it's considered a partial hospitalization. That's one that's seen a little less commonly than some of these others, the traditional outpatient sort of programs. And most people are familiar with the idea of being inpatient or in a residential sort of setting. And they're grouped together here because you aren't living at home, and so often they are looked at in a similar light, though inpatient relative to mental health often indicates a sort of locked unit, a traditional psych ward that people would think of, whereas residential often isn't nearly as restrictive, but it still does involve 24/7 staffing and monitoring. And so it tends to be a higher level of care than we'd see on an outpatient basis. And really when people are reaching out and seeking treatment or seeking advice, this is often sort of the crux of where the decision making comes in. Does someone need to start with outpatient therapy? Do they need to see a provider to provide to potentially be on psychiatric medications? Do they need to engage with more of like peer support groups or doing more self-help and focus on their wellness? That could be something that from a medical standpoint, we don't even necessarily consider a true level of care, but that might be what a lot of people are doing before they're actually seeking treatment. And sometimes when people's first entry into treatment, it might be more intensive and requiring something like inpatient or residential. And certainly in the substance use realm, we see residential treatment an awful lot. The proverbial rehab experience is typically residential care. And so the idea of removing people from, the substance or their environment where they have access to these sorts of things for an extended period of time so they can be undergoing treatment and hopefully return to their lives with better equipped to deal with it. Um, and this is one of the biggest questions that people face when they're first entering care is what do I actually need? How intense do I need of treatment? But this slide sort of spans the gamut of options or intensities, I should say, of treatment. Again, there are so many different types of psychotherapy and therapeutic interventions. Tried to cover this somewhat high level so that we could, go more in depth if people have specific questions about certain types of treatment or certain situations. But some of those commonly utilized forms of therapy would be cognitive behavioral therapy, certainly our most utilized type of therapy. We look at how our own thoughts influence our behaviors and try to work on some thought restructuring. Um, how do these thoughts that I continue to have end up impacting my day-to-day behaviors? And can I challenge that? Can I think about it in a different way so it's not so disruptive? And dialectical behavior therapy, that's is something that we use in our program every day. And it really focuses on the interplay between our emotions and behavior. Right? So we try and work on coping skills for how to better regulate our emotions. How do we tolerate distress in a more functional way so that we're not relying on a substance to help cope with things. But really focusing on how do we regulate our emotions in a way so our behaviors aren't as negatively impacted. And psychodynamic therapy is often a longer term sort of outpatient type of therapy where focusing a lot on relationships and building insight into our behaviors and our like patterns of behavior, so we can hopefully help make some amount of change and some reform. Um, EMDR is another commonly known type of therapy, often used within those that have PTSD or have experienced significant trauma. And the concept is sort of helping with reprocessing, so that the brain isn't as reactive or as sort of stuck in a lot of our ways of thinking when it comes to people that have experienced substantial trauma and sort of how it influences their views on life. And we also have family therapy, couples therapy, and sort of the name speaks for itself in a way, but often working on communication, relationship dynamics, having someone sort of moderate these conversations and help the couple or the family process in a way. Um, and then group therapies can really range in terms of peer support, where they're peer-led meetings. Oftentimes they are led by clinicians and can have a sort of underlying therapeutic theme. Like there are certainly DBT-based skills groups, CBT-based skills groups, those sorts of things. But often getting a number of people together that have similar concerns or similar troubles and working within a group, people often sort of grow and learn from one another. It can really be a powerful experience a lot of times. And so there's certainly far more than this, though. I wanted to hit some of the high points, as well as common types of psychiatric medications in case people had questions about these certain things. But often, antidepressants are one of the most commonly prescribed types of medications. The terms SSRI, SNRI, often referring to the sort of chemicals they work with in the brain, serotonin, norepinephrine. There are medications that are focused more specifically on anxiety. Some of them are daily medications, some of them are more situational, like benzodiazepines. People are often familiar with the common names of those, like Ativan or Klonopin, Xanax, those sorts of things. Mood stabilizers like lithium or Depakote, and antipsychotics are often also pretty commonly prescribed, can be used as additive treatments in a lot of these conditions, even in those that aren't particularly psychotic. As well as stimulants are pretty commonly used for treatments as treatments for conditions like ADHD. Can also be used at times for narcolepsy or certain neurologic conditions, really helping with attentiveness and sort of impulse control. Those are sort of large categories of medications, and certainly some things kind of fit in more than one category and can be used for a variety of reasons. But trying to give a more overview, these are the larger sort of designations of these sorts of medications we would see. So, and then just to review some of this rather quickly, there's somewhere in the neighborhood of 50 million people in the US have a substance use disorder. We see um, um, uh, just slightly more than that are also having mental health sort of diagnoses. Um, That's in the neighborhood of 70 something million. But only about 20% of those with substance use disorders receiving treatment. We see alcohol, nicotine, cannabis. They're still most commonly used substances. That hasn't necessarily changed, although cannabis is really on the rise. And we are actually seeing a lot of these measures improving over the last several years, with the exception of cannabis, which is still rising. And again, the idea how stigma might play into this sort of thing, and decriminalizing cannabis and how that can really almost enable or promote use amongst folks. And then adolescence is seeming to show progress with depression and a lot of the suicidality measures, which is great. It's something that's been rising for quite some time. We're seeing improvements, but generalized anxiety is still quite prevalent within adolescents. And then I wanted to include this, and hopefully this slide itself can actually get sent out as far as some basic options for people to reach out to, resources that can be a place to start if there isn't a great place or person for people to reach out to in terms of seeking help. It's sort of broken up there in terms of whether it's a crisis and we're needing immediate support, or if like for myself or a loved one to get help but aren't quite sure exactly what I'm looking for, more informational. The Samson National Helpline can be quite helpful with that. So I kind of brushed through a lot of that here and sort of high level, but to make sure I opened it up and gave time for folks to ask any questions they may have.
Dr. Wade, I think you definitely have stimulated some ideas in people, some questions. I see some questions coming in already. The first one is from Alice. Let me go back. Sorry. Looking ahead 10 to 20 years, what is the one research development that gives you the most hope for reducing addiction and improving long-term recovery outcomes?
It's a great question. I would say what I probably have most hope for at this point actually are the GLP-1 medications that are becoming more and more popular. There's actually a lot of data coming out about how they are helpful in reducing more compulsive type behaviors, even beyond just eating and the appetite and everything. We see it be helpful in reducing sort of like skin picking behaviors, hair pulling behaviors, some compulsive behaviors, and substance use appears to be a part of that. Certainly with alcohol use, there's actually quite a strong signal in the data, and there's a pharmaceutical study actually going on currently looking at, I believe it's semaglutide specifically for alcohol use disorder in terms of treating alcohol use disorder. We do see it with a number of other substances too. And certainly, these are things that more and more people are using. We're getting more and more safety data on. They have other health benefits. I mean, it's probably the most promising tool we've seen in a while, and it seems to work relatively broadly. And we're still sort of discovering why, or maybe science has a little bit better of a concept of why than I do personally. But we're looking a lot into it because it seems like it's quite promising.
It's interesting you say that because I do know a few people who like their glass of wine at dinner time, and since they've been on their GLP-1, it's like not just the food noise, but the alcohol noise has been erased. Like they just don't enjoy it anymore.
Yeah, absolutely. I think it's certainly something we hear from folks. I think it's a happy accident that we're finding this stuff, but I really think we're putting the money and the time and research now to explore that because I think it has promise.
Thank you for that. And so we have also Alexis. Hi, Dr. Wade. Thank you so much for your presentation. It was very informative and enlightening. You mentioned that oftentimes a partner will recognize the signs of mental health because of the impact it has on the relationship. What are some supportive ways to start the conversation towards seeking help?
Yeah, it's often one of the toughest parts, because it is, especially when we're talking about mental health, people have this sort of a stigma or judgment of themselves, even having potentially some of these concerns, and so it can feel like we want to tread lightly. We don't want to pass judgment on them or how they're dealing with things. And we often feel like we might be. So I always advise folks to come from a place of concern, which, we all know it does. It's always coming from a place of concern at the outset. Though voicing that is really important. Like I'm saying this because I'm concerned. This is something I've been seeing where I don't know if you're aware of that, how this or whatever the behavior or anything might be. I don't know if you're aware of how this is impacting me, and I wanted to share that with you. And also reinforcing the idea that there are treatments out there, there are resources out there. This doesn't just have to be something that we're going to argue over. This doesn't just have to be something that causes us trouble in our relationship. Like, this is something we can address. And so, being very clear that it's not intended to pass judgment. It's not a moral failing. It's not a character issue. It's something you're bringing up out of concern because it seems like it's troubling to them, and it's troubling to them and can be. It's something that they can get relief from, that they can have some improvement in. And, we all want the best for our loved ones. And that's really what the framing is. They see something that they can potentially get help with. And, you want the relationship to work. You want it to last. You want to stick with them. That's the whole point in working on some of these things, because it is impacting the relationship in a way. And always framing it from how you feel towards them and how you want the best for them.
So other than approaching them in a concerning, in a non-accusatory way, what other support could a loved one provide to someone who has a mental health or an addiction issue?
I think, having some of the resources or potential options ahead of time, I think, can be helpful. If the person has to do less of the legwork or less of the decision making, sometimes it reduces some of those barriers, right? It may very well be that when they hear the concern be brought to them, they're like, oh, I've thought of that too, but it's just so hard to get in to see a therapist, or I don't want to go to residential treatment. I don't know if I can leave work or that sort of thing. Having some part of the process that you've already done a little bit of legwork on for them can really reduce some of those barriers. You do want to make sure that you're still giving them, the choice. Like, this is still something that they're choosing to do. You don't necessarily want to make the decisions for them. People have to have some of their own agency, but if you're concerned, if you're concerned and you've put in, a lot of time and thought into this conversation, a little bit of research can go a long way in terms of providing them a starting place, because it can be really difficult to decide on something. It can really be difficult to pick up the phone. You can even support them and offer to, be with them when they call, or bring them to an appointment, attend something with, like, being supported through the process. Really, really is important. And nobody does these things alone. Like, yes, the individual goes to treatment. They're the one in all these sessions, but it's a team sport when we're working with addiction, when we're working with mental health. It affects all those around us. And
Yes,
so really being there and being supportive is crucial.
yeah, even a silent supporter means the world to somebody who's doing this alone, someone who's just there with them.
Absolutely.
At what point would you say someone should consider medication, in addition to like the cognitive behavior therapy or any other therapy, talk therapy?
Yeah. I mean, despite what I do, my approach is generally therapy first. I honestly think so much of the heavy lifting gets done in therapy. The idea of being in therapy is not just to vent about your problems. It's working on how we think about things, how we cope with things, how we react to things. it's trying to build ourselves up and develop a framework so that we can deal with not only what's bringing us to therapy right now, it's to help us in the future to deal with these things. And so if we're better prepared to navigate all these things in the future, we're less likely to be negatively impacted. If we know these particular things make us anxious and we have some skills with how to cope with them, you know, we can theoretically do that in a lot of future situations. So I'm a big proponent of therapy first, where I see medications be most useful. And there's certain circumstances where I might say, like, I feel like medication is necessary. Very few cases where I'd say medication is necessary, but oftentimes in the therapeutic process, a lot can come up for people and it can be really difficult to manage. Like the intensity of the emotion is just too strong, too raw, too intense. And if we're, sort of boiling over, like if our temperature is running too high, I mean, none of us are processing well, none of us are thinking as clearly, none of us are really going to make that needed change or insight. It's going to be really difficult to functionally participate in therapy if we're just running too hot all the time. And if medications can kind of help keep us in a little bit cooler of a headspace, a little bit greater capacity to actually engage with the therapy and get what we need to get out of it. That's where I think medication can have its best sort of influence. Yes, there are certain conditions like things like schizophrenia or these psychotic disorders where the thinking can be so disorganized and out of touch with reality that therapy can't be the starting point. Like medications have to be the starting point and try and reel some of that in. But for a lot of what people are seeking treatment for, I find therapy does a sort of heavier lifting.
Yeah, that's a great point. Um, the next question is actually a two-part question. You touched upon this before when you start talking about how costly healthcare can be, and you start to talk about insurance companies. Um, the first part is, where would someone start treatment for mental health or addiction issues? But also, we've noticed that there are many healthcare providers and nurse providers who no longer accept health insurance. It's all out of pocket, especially with mental health. And so this creates another hurdle for care access for so many people. And so, um, what do you say to that? And also someone who's watching you tonight who's thinking, hey, maybe I'll give him a call, Do you also have your own private practice and do you accept insurance?
Yeah. So the second question is a little shorter, so I'll start with that first. I do see people privately, and no, I do not accept insurance, and in part, it's a number of things, to be honest. One, because I have other work that I do. My primary job is with Silver Hill and running the residential program, and also the affiliated New York outpatient program. That takes up an awful lot of my time. And so they're kind when they say it's a full-time job. It's more than a full-time job, but I'll let them slide on that. And so I do see some people privately outside of, typical working hours, but when it's going to be such a small portion of what I do, the idea of going through all of the insurance payer credentialing and all of that, that's all of that paperwork, all of that sort of rigmarole, if you will. I don't need that many patients. I'm not trying to build that large of a practice. Um, the other piece is just how they regulate everything. And so this kind of gets into more of like the first part of the question where, why so many people are going into cash pay and or self-pay models and not directly accepting insurance. It's because of how much they place on you from a regulatory standpoint, and then the fact that the reimbursement isn't necessarily commensurate to a lot of that work. I have to make sure I'm hitting all these different documentation points. I have to meet all these sort of like different quality, arbitrary quality metrics that they'll throw out. They have to audit my records, all this kind of stuff if they're going to reimburse me. And also the reimbursement rates aren't that great. And so it's a lot of extra work. And so for someone that's just working with a small private practice, it's sort of a non-starter. What is good for people if they are able to at least for the upfront out-of-pocket cost. A lot of providers are able to provide super bills, people that can submit to their own insurance companies for reimbursement to get some money back from it. But ultimately, being as operating in a cash pay or self-pay way, you get to make more of the rules effectively. You can spend more time with a patient. It's like, yes, I may charge more, but I can give you a lot more time than if I need to see so many patients because the reimbursement is so low just to pay for my overhead. And so, there's a certain amount of quality and less restriction that you can have from a cash pay model. And so I think a lot of people are recognizing that, particularly within the mental health space. 15 minutes may be enough time for certain medical concerns or brief medical visits. But when we're talking about mental health, like, yes, some appointments can be 15 minutes, but often, there's a lot more going on than just the effect of the medication. And to really understand that, you often need more time, but insurance isn't going to pay you for spending more time with
Right.
people that way. And
Okay.
so being
I'm
able
just
to do
thinking
that
maybe
when
there's someone in our audience who may want to reach out to you after this, but you also mentioned in one of your slides, you recommended apps and peer support groups and self-guided tools. Is that something that maybe you have a list of that you can share with me and Tiffany, and then we can share with everybody else on the PALCUS website?
Yeah, I can give you a few of them that you could disperse. There are different ones, like certain like peer support groups and that sort of thing. Like there are nice databases for those sorts of things. A couple apps that can connect you to others and for sort of therapy services and sort of some of it can be peer support. There's a We don't have time to get into like AI therapy and all of that, but
Yeah.
there are certainly those sorts of apps and things out there as well.
Okay. I'm sure we could keep going and asking you questions, but we are at time. I did want to just say quickly, um, two observations from looking at your slides. And I had already looked at them and they kind of were like staring me in the face today, unlike last time. But I was shocked at the vaping statistics in kids ages 12 through 17, 71%. So my kids are now in their 20s. When they were at that age, I remember them coming home saying, wow, so many kids vape in middle school and high school. And I guess when I was that age, it was smoking. So that was something that really stood out. And then on one of your slides, you had generalized anxiety disorder and how it dropped. The statistics dropped from 2021 to 2024 by 26%. Do you think, well, it dropped in terms of major depressive episodes. Do you
Mhm.
think that had anything to do with COVID? That people were out and about, by 2024, or were there other trends at play?
Yeah, so I suspect that's probably the biggest piece of it. When I think back to, and I probably should have pulled up the number for this presentation, but when I think back to the data from 2019, um, it was close. I do believe it was close to 20% in terms of major depressive episodes for adolescents. So I know that 2021 statistic was the highest number that we've seen, but I do believe that even before the pandemic, like we were seeing some relatively high numbers. Where that improvement comes from, it's going from 2021 to 2024. And I think 2021, we're still sort of coming out of the pandemic, right? And so I
Mhm.
suspect that's part of why that number was so high and maybe we're kind of getting close and closer back to baseline. But I think it is still worth noting because many of the people in many of the adolescents in 2021 might still be adolescents now in 2024. Like they've experienced some of that and it can really derail their formative years. So
Right.
I still think it's pretty notable. But I agree that 20-ish% number I do think was likely influenced by COVID. It's the highest one we've seen.
Yeah, makes sense. Does anybody else have any other questions? Um, Hold on, let me go back. Let me see. Anybody want me to put them, unmute them? Alice said, thank you for such an informative session. I think we have all the questions. Um, I did want to formally thank you, Dr. Wade, on behalf of PALCUS, myself, and Tiffany. I know it takes time to put a presentation like this together, and obviously taking time out of your evening to speak to all of us. We hope this webinar provided our audience with some resources and information that they find helpful. When I end the webinar, please stay on because there is a survey at the very end. And it's only like 3 or 4 questions. It helps us gauge if our topics are timely and relevant. And if there's a topic that you would like to see seen on a future webinar, you can also write that in the comments. You can also follow PALCUS on our social media sites. We're on both Facebook and LinkedIn platforms. And you can check out their webpage, www.palcus.org. There's past webinars on healthcare topics, but there's also information in there spanning from legal to economic, employment, and it's not just for people of Portuguese origin. I think a lot of people would find it helpful information. So, any last words, Dr. Wade?
Just thank you for the opportunity, and please feel free to reach out with any questions or if I can be helpful in any way.
We appreciate you. Thank you so much. Have a good night, everyone. I'm going to end this, and then the survey should, let's see, hopefully I don't mess this up.